Welcome to the Teaching Value and Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health systems innovations to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Costs of Care and the ABIM Foundation created the Learning Network as a space to share ideas, education materials, and strategies in an open forum. Our goal is to discuss ways to get started and implement and sustain feasible changes at your institutions. The Teaching Value Healthcare Learning Network has three major components. One is monthly webinars, in which today you'll see a 30-minute session to hear on-the-ground and national leaders share the successes of innovations and talk about implementation. The second are discussion or affinity groups, which is an online forum to ask questions and gain advice from others around the country and in Canada. And the third is our toolkits, which is a place to share and disseminate curriculum and other slide decks and tools for the implementation process. Finally, we have a section to present publications and presentations that come out through our group. So I'm Reshma Gupta, the Director of the Learning Network, and will be moderating today's webinar. Today we will share an innovation of teaching value and discuss in-depth practical components of implementation, including how to obtain buy-in, resources needed, and advice about sustainability and feasibility. We are honored to have Dr. Vivian Lee today. Dr. Lee is a radiologist, PhD, and MBA by training. She's the CEO of the University of Utah Healthcare in Salt Lake City, Dean of the University of Utah School of Medicine, and Senior Vice President for Health Sciences at the University of Utah. She's published over 150 peer-reviewed articles and was recently elected as a member of the National Academy of Medicine. Dr. Lee came to the University of Utah in 2011 and is focused on increasing efficiency in healthcare, transitional research that can change medicine, and innovation to spur new technologies and medical breakthroughs. While she has an extensive and very impressive list of accomplishments, she noted her preference to have a short introduction. So though I will mention that her work was recently featured in New York Times September issue entitled, "What Are a Hospital's Costs? Utah System is Trying to Learn." I'll let Dr. Lee take it away. We're honored to have you join us today and to hear more about your work.
Well, thank you so much. It's really great to be here. I'm just putting on my slides now. And do those look okay to you?
Those look great.
Terrific. Well, it's really wonderful to be here, and I'm very honored to be a part of this. Well, what I thought I'd do is just start by giving you a brief introduction of who we are here at the University of Utah, because as you know, if you know one academic medical center, you know one academic medical center. And so who is the University of Utah? Here's a summary. We're, I would say, a medium-sized health system with 4 hospitals, 11 clinics, about 1,400 employed physicians. We are the only academic medical system in the entire state of Utah, also covering Idaho, Wyoming, Montana, about 10% of the geographic landmass of the U.S. And we see about 1.4 million patient visits a year. I think one notable fact about Utah is illustrated in this slide when we're talking about the transformation to value. I think this illustrates it well. So each of the dots on this slide are one of the 50 states, and on the y-axis is affordability, which means the healthcare expenditures per person per year. And higher on the slide is better. So Utah is actually the lowest in the country at about $5,000 per person per year. And on the x-axis, it's the healthiness of the population. And going to the right is better, more healthy. So Utah is pretty much consistently around number 6 or 7 in the healthiness ranking. And so when we define value for a population in this transformation to value, we think of it as the best health, the healthiest population at the lowest cost. When we talk about it internally, we define it as this equation. So the value equation that we use here at the University of Utah is a significant factor is quality or outcomes. We also really emphasize service or the patient experience, and I'll talk about that in a moment. And then, of course, how do we obtain these at reasonable costs? So I have essentially one slide to illustrate or to summarize what we've been doing in each area here. In quality, the system that we value the most is the University Health System Consortium ranking. So every year, all of the university health systems, we pool our quality data in University Health Systems Consortium's database. There's a scorecard that's used to evaluate quality, safety, patient satisfaction. And when I joined the university and when I was being recruited was in 2010 when the University of Utah was #1. This data really impacted my decision to come here. When the hospital CEO joined us in 2007, we were about the middle of the pack, and in 2 short years we were able to move from being in the middle to being #1 in the country among all university hospitals in quality and safety. And for the last 6 years in a row, we've maintained a position in the top 10. And so this is something that we continue to work on. The patient satisfaction story started with my predecessor, Laura Spetz, in 2008, and I think again illustrates the results of an effective strategy for transformation. In 2008, we were about average middle of the pack in terms of patient satisfaction. What I'm showing here in red is the percentage of our providers who are in the top in the country in patient satisfaction, and in orange the percentage that are in the top 10 percentile. And you'll see that right now about a quarter of our providers are in the top 1 percentile and half are in the top 10 percentile. And then finally, in bending the cost curve, here are the data from all the university health systems for the last 6 or 7 years. You'll see that the annual growth rate was about 3% in total facility expense per CMI adjusted discharge. And here at the University of Utah, we've been able to bend that cost curve. So if we were to summarize what we've been achieving so far and what we're continuing to work on, it's really shown in this slide. So what I've been asked to talk about and think about is to discuss what is it about our culture here and what have we done at the University of Utah over the last few years to really achieve these kind of results. And I'd say it would be summarized in this slide. It's really about engaging patients, which we all know and we've talked a lot about, but I think the secret sauce is really engaging providers. And that is the part that I think we haven't focused enough on in our discussions about healthcare transformation. So I thought I would start by talking about engaging providers and then talk about how that has led to patient engagement. Engaging providers in the transformation, I think, has been critical to our success, and really one fundamental element is using data to engage providers. And I just want to make a point by saying that I think in some ways, in some venues, data have been used almost as a gotcha with providers. You know, we share data about providers publicly in a way that can be very embarrassing or highlights some of the bad apples among providers rather than using data in a really productive and learning way. And so more recently, Toby Cosgrove and Tom Lee wrote this nice paper in Harvard Business Review about engaging doctors in the healthcare revolution. And we actually have a paper coming out in Academic Medicine next month talking about our physician engagement story. It started, I would say, in 2008 when my predecessor, Laura Spetz, said to the organization, medical care can only be truly great if the patient thinks it is. And what he charged us to think about is how to be a patient-centered institution. And he specifically charged the providers. The first step was to develop a data system to collect data. We didn't really have any data about patient satisfaction and patient experience. And so we used the Press Ganey database of questions, and specifically we focused on questions that targeted patient communication, patient engagement in decision-making, in respect. We started off with mail surveys to all of our patients, both in and outpatient, and now we're electronic. And then because we used the Press Ganey database, we were able to benchmark the results. If a physician, for example, got 4 out of 5 on this scale, did that correspond to being in the 20th percentile compared to their peers or in the 90th percentile? That benchmarking was really helpful. This is the kind of data we would provide back to a provider and the typical kind of results we would see. So here's a new cardiologist joining our system in 2011. And here are the different responses to the questions in terms of that national percentile. So you'll see in 2011, this provider was around high 20s, low 30s in terms of percentile, color-coded in red, just to reinforce that we wanted some improvement there. And then over the next couple of years, by the sharing of best practices, by using some SWAT teams, a lot of peer-to-peer teaching, we would see this typical pattern of improvement up into the 70s and 80th percentile. And so across the board, that's how we were able to achieve that high growth in patient satisfaction to where now half of our providers are in the top 10 percentile and a quarter are in the top 1 percentile. The rest of the value equation, we are trying to follow a very similar algorithm, a similar strategy, obtain the data first and then share it with our providers in a progressively transparent way. And the quality and cost piece, I think, has been more challenging. Not in the quality side, we have quality measures, and we can discuss whether those are really valid outcomes measures, but we do have a lot of quality measures. The cost side was much more challenging for us. And here what I'm referring to is the true costs of care, not charges. This observation has been made by many others outside of healthcare, including Tom Lee and Mike Porter, who said, for a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. And so we set upon this project about 3 years ago to really cost out healthcare, what it cost us to deliver healthcare. And here's a schematic that would give you an example of a patient coming in for an appendectomy, say a couple of days in the hospital, from the OR all the way out to beds, and each of those components, the ER, the operating room, all the way down to the floor units, we could total the costs of care for that patient. And so here's an example of what we could do with that data for our orthopedic surgeons. Now we've just limited to major joint replacement of the lower extremity, and you can see for our 10 orthopedic surgeons, the average cost of care varies considerably. Each of the color components is one of those, whether it's length of stay or operating room time, provider expense, or so on. And just by giving this data to our providers, together with the quality data, these are the kind of results we could achieve. In the blue, the quality index, the providers define their own index, and we're really driving quality up. And as they're driving quality up, we saw a cost reduction by about 30% without any financial inducement or incentive. This is the pattern that we've been seeing pretty consistently across our organization, and this is the article that Reshma alluded to that was in the New York Times talking about our cost. And similarly, we can cut across entire components of our organization like operating room areas and develop whole toolkits that look at operating room efficiency. So we're not just looking at department by department, but across the system. Now I'm just going to spend a couple more minutes talking about engaging patients as partners, because I think once the providers are engaged, then we can really think about patient engagement. And let me just turn back to this patient satisfaction story that I already showed you and talk about a pivotal moment in 2012 when my chief medical officer came to me and said, you know, we have all this great data about patient care, lots of patient comments, about 60,000 a year returned to us, and we would never pick a restaurant without looking on Yelp or a hotel without looking on TripAdvisor. We should really provide that information to our patients. And so in December of 2012, we decided, as part of engaging our patients, to post our patient satisfaction scores online. So here's Courtney Scaife, one of our general surgeons. On her webpage, like all of our provider web pages, you can see her raw score from all of the patients that rated her. And if you scroll down, you can see the individual questions, and if you scroll down further, you see all of the patient comments. Very impactful, I think very effective engaging patients. We've charged the whole organization with continuing to move that forward and really imagining perfect care for our communities and patients. And here are 3 initiatives just in one of our clinics that's rolled out in the last year. In-clinic childcare. This clinic serves very young families so they can have access to childcare for about 4 hours as they get their health care in our clinic. In-home newborn visits, so we put a nurse and a pediatrician get in a car, they drive around this neighborhood and they visit those moms or dads and their new babies at week 1 and week 2 so that they don't have to bring them into our health clinic. We think it's much more patient-centered. And then one-stop shopping, starting with women. Scans, dermatology, pap smear, mammogram, all in one visit. So we're really trying to move into a much more patient-centered model. And then let me just finish with one more idea, which is that we are also very interested in thinking about our definitions of quality and really moving it more into the patient-defined quality, patient-defined outcome space. Here's a picture of Charlie Saltzman, our chair of orthopedic surgery, who has really piloted this and pushed this forward. Every patient who comes into our orthopedic center gets an iPad, goes through a series of about a dozen questions about their physical function, their psychological function, and their social well-being. And we really want to incorporate patient-defined measures of outcome and quality into our value equation. So I think I'll finish there and just mention that we are looking to partner with other institutions. We have a Robert Wood Johnson funded Value University program, a number of online tools that I'd encourage you to take a look at if you're interested, that talk about training the organization to be really value focused. And also other online printed materials with our annual report, Algorithms for Innovation. And so with that, I will maybe conclude my remarks, and then I'm happy to take questions.
Great. This is perfect. Vivian, that was a wonderful outline of all of the amazing work you all are doing. I'll have you actually cancel out the share screen off your slides so we can have more of a discussion with our group and can see both of us. Perfect. But that was a wonderful way of going over both how you initially approached culture change in terms of engaging providers, as well as now moving towards how we really engage patients. And I want to just let the audience know that if they click in the right-hand corner of their screen, there'll be a section for Q&A, and they can actually post up questions that I will then moderate and kind of ask up Dr. Lee. But just to start us off, I did want to ask you one thing, which was, I think that comes up frequently. I've heard you speak a few times now about when you're initially engaging providers and kind of thinking about other folks in the country that are just embarking on this work. What do you do and what do you recommend in terms of getting that buy-in and getting providers used to the idea of seeing their own data or having it kind of out there in the world? And what approach or advice do you have for folks?
So that is a great question, and I do get asked that pretty frequently. I think that one of the lessons that we've learned here is that all of our providers really want to engage in these questions. They really want to be a part of the healthcare solution. We all read the newspapers. We all understand that healthcare is in a crisis. We actually pay our own healthcare premiums and see them go up. So I think we all know that there are issues that need to be solved. A critical piece is the data, is the ability to actually measure and provide that feedback back at the level at which it is actionable to the providers in a way that's clear, and to provide that data in a way that is intended to be educational and informative but not punitive. With the patient satisfaction data, you can imagine that if we just gone online and posted everyone's scores from day one, it would have felt very punitive. It's actually a little bit unnerving to have all of the patient comments about you. Many of them are quite personal, posted online. And so the way we did it was a much more gradual approach to transparency. So we gave the data to the providers first. We provided a lot of opportunity to improve, peer-to-peer training, SWAT teams that would come in and work with the receptionist staff, work with scheduling template, all kinds of ways in which we could try to help the teams improve. So that by the time we went online, I think all but 2 or 3 of our 1,200 providers at the time, all but 2 or 3 had at least a 4 out of 5 stars. So it didn't feel punitive, and they could have that chance to improve before the data became fully public. I think that's been very helpful, a very helpful set of lessons, and I think what we're really doing is tapping into that inherent competitive nature of most physicians who really always want to improve. They're very driven, and if we can tap into that, there's a lot of good that can be done.
Absolutely. And I think one thing, there's a number of things that you brought up which I think are very interesting, but one of them is when you first decided to embark on this, you approached patient experience and patient satisfaction as the first thing. How did you decide on that first? Do you think that's something that you would recommend in other groups that are embarking on this, or do you advise choosing the first thing in a different way?
Oh, that's a good question. I don't think there was a strategy to say, let's start with this and then do this and then do this. The work around the exceptional patient experience was really initiated by my predecessor, Laura Spetz, who was the senior vice president and the dean and CEO before me. And he, I think, really just got fed up with patients complaining and with scheduling challenges in clinics, the things that so many medical systems have faced. And he said, it's just time to fix this. As he said, if the patients don't think we're great, we're not great. And I think in retrospect, it was a brilliant move, because what it really did was it focused all of our attention across the entire enterprise on the patient. It had an unintended consequence, or maybe it was intended, I shouldn't say it was unintended, but it had an incredibly effective consequence of making us patient-centered. And I think critical in that transformation was the fact that we selected the patient satisfaction questions very carefully. So we didn't ask about food, we didn't ask about ambiance or the parking or, those kind of issues. We asked about the patient-physician relationship or the patient-provider relationship, so that what we were all focused on improving was that relationship, that communication, that joint decision-making, and then, of course, some logistics like wait time. And that has been so effective, that has been so important for us. It has increased referrals dramatically. Our volumes are just incredible. Our medical malpractice is decreased despite a threefold increase in our volume over the last decade. So there are just many secondary benefits, and the quality, our quality has improved. As you saw, we were in the top 10 in quality for 6 years in a row, and I have no doubt that better patient communication and patient engagement leads to higher quality. So I think it's just created this real virtuous cycle for us.
That's a really kind of wonderful story to hear it, not only that approach, but then to see the outcomes of that as well. I think one of the things that often comes up in our own institution here is that when you're choosing to embark on what to approach first, really wanting to engage the provider so they believe as well that this is really important for their patients, as they're the kind of forefront at the face of the patient. And so it's hard to argue that that patient experience isn't important to everybody. And so I think it's great that that was something that you were able to start with and see that change. One thing that you mentioned, though, was that for these providers that had room for improvement, that you use SWAT teams, and it wasn't just the audit feedback, but it was also the coaching component, and kind of gently, gradually getting them on board. Could you describe what that involved, especially for those out there that are thinking about how to do this in less punitive ways?
Okay. Well, so first a disclaimer. So I wasn't here at the time when it was all first started. What I understand and what we wrote about, as I mentioned, there's actually an article in Academic Medicine coming out next month that describes a lot of these, and it gives a little bit more flavor into some of the different best practices that were shared and adopted. But one of the things that we did a lot was to enable people to share best practices with each other. So we had a lot of venues, retreats, opportunities for one team to share with other teams things that worked. So, for example, on the inpatient side, this seems so simple, but on the inpatient side, one of the teams created a very simple handoff from nursing shift to nursing shift, where the nurses would introduce, they would of course write their name on the whiteboard, they would introduce the nurse for the next shift, and they would tell them something personal about the next shift nurse, so that the patient could anticipate this new person arriving and kind of start to develop a connection with them even before they came. So that was created in one of the floors, I can't remember which unit, and then they shared it with everybody else. So of course it just permeated across the institution. So there was a lot of freeing up people to think about, what do you think you could do that could make this environment much more patient-centered, and then sharing that. The other thing that happened also, I think early on, at least what I was told, was that we sent teams out to look at other industries. So there was a team that looked at Apple, to talk to Apple. There's a burger chain here called In-N-Out Burger that's really known for customer service, and so our team went and talked to them and talked about how they work with their staff. So there was also looking externally and trying to bring some of that in.
Great. One question that just came up as well. So when you're talking about engaging providers who are very busy in their work days, is there an approach, or is there advice that you have about, providers who are kind of new to getting this data back, new to finding out about how they're doing, and not wanting to overload them with extra work?
Well, you mean the challenges of just bandwidth for most of our providers in taking on all the extra data? That's definitely true in the quality space, I think, because there are just so many quality measures. In the patient satisfaction space, it was much simpler because we only had these 10 or 12, 10 or 11 questions, and so the feedback could be just returned in those same color-coded charts that I showed you in one of the slides. On the quality side, what we're actually trying to do now is to break down all the quality measures. Well, we've actually already done this, but we break down all the quality measures and we just limit the key measures that we want each team or each provider to focus on, and just try to make it a little bit more manageable. We rolled out our electronic medical record Epic system last year. There were a lot of issues about bandwidth for our providers, so we are really sensitive to that and trying to make it as manageable as possible.
Great. One question that popped up as well is the resources that are required for this. So, thinking about obtaining these metrics, and especially in institutions that haven't embarked on doing this before, what did you need, and kind of the personnel that you needed to get metrics that are reliable, so you can kind of provide this data in somewhat real time back to providers?
Well, the question really differs depending on which part you're asking about. So on the patient satisfaction, it was much more low tech. We partnered with Press Ganey to get these questions. We had about 2 or 3 employees in the beginning. Now we have 4 employees total running our Exceptional Patient Experience Initiative. So they partnered with different people in the organization. For example, they worked very closely with somebody in IT who helped, for example, move our scores online. So that was a little bit of a project. But overall, that has not been very resource intensive. When it comes to the costing project, I think that is a lot more complicated. Of course, we have a big team that does all the quality metrics. I think most systems have to have at least some personnel in order to manage all that. The costing project was really interesting because as I said, it's not about the charges, it's about really understanding our costs, and we have a lot of complexity in the healthcare system. And so when I asked the team, I brought a team together of IT and finance people and bioinformaticians, and I said, what would it take us to build a tool that would show me quality against cost, the value equation? And I want it for every patient, every provider, every diagnosis, everything in our system. And they said, okay, well, we have the quality piece. We have to actually cost out everything. And the way we did that was actually very resource limited. We took existing employees from IT, from finance, departmental administrators. A lot of our bioinformatics faculty actually participated in this. And then we did what we called a sequestration. We put them in a building in Research Park, which is just over here by our campus, and we asked them to do this 3 days a week while still doing their day jobs. So, and they did it, and within about 5 months they put together this prototype. I think many institutions have asked us, what would it take for us, at their place, what would it take for them to build out the same costing tool? And I'm not really sure, because it depends on how well developed their data warehouses. If they have a good data warehouse, we were building on a really robust data warehouse here, and so that's why we were able to do it so successfully. Our team has actually been building out a tool that could be used by any institution, and we're looking actually for beta sites to partner with us. So if there's anybody watching who is interested in being one of those sites, we're starting with people who have Epic, and then eventually we'll be moving it out more generally, because we would really like people to have access to this tool. I think it's really empowering to know your costs and to be able to share it with providers. It's been transformative for us already, and I think if we can help other institutions do this, we're very interested in doing that.
Yeah, I think there's definitely going to be interest on that, and especially with Epic being so broadly used. So thank you for sharing that. One question that also came up is, when you think about the efforts that you've done with provider engagement or even on the patient side now, can you think of examples where your staff or your team has faced barriers that came up and how they've tried to overcome them? Especially from the setting of folks that are just embarking on this work, for them to think about things that might pop up or how to triage some of that.
Well, okay. It's a good question. I think that when it came to um, I think the one key component is always to remember that there's two parts of the transformation. There's providing the data, and then there's providing a bit of a skill set or education for people to know what to do with the data in order to translate that data into improvement. Certainly most of us who went to medical school didn't go through any training in process improvement and lean, in the sort of skill set operations, how do you actually make a clinic more efficient. And so if you just give us the data and we don't have a way to improve, it's going to be frustrating. So one of the things that we learned here had to do with how to train providers in lean and process improvement. There's a tendency, I think, for some organizations I've heard to push lean out, and they say, we're going to do a lean initiative, we're going to train everybody in lean, and it sounds like a cost-cutting exercise. It doesn't really sound very satisfying, and in fact, some staff worry that it means that their job might be in jeopardy, if you're going too lean. The way we did it here, I think, worked out really nicely, so maybe I can share that story with you. When we rolled out Lean here, we partnered with our business school. So first of all, we have a lot of expertise, of course, in most business schools. Most teaching hospitals are affiliated with the university that has a business school. And so we tapped into our business school and we asked them to partner with us. That was super helpful. And then the way we rolled it out across the system was we said, think about a problem that's in your daily life in the clinical setting that drives you crazy. Whether it is operating room starting too late in the morning, starting late, or turnaround time in the operating room or in the cath lab or in any procedural setting, or having to fill out the same paperwork 14 times, or clinics running late at the end of the day. Any problem that just drives you crazy. If you can bring the team together, all of the people who are responsible, plus the person that they all report to, the person who's actually responsible for that entity, if you can bring them together, we will put the resource of a business school faculty member or a value engineer from within our system to help you do process improvement there. And so that's how we rolled it out. We didn't roll it out as a cost cutting or anything. We rolled it out as what drives you crazy, and let's help you fix that. And what that enabled people to do was to sink their teeth into a problem that had been driving them crazy, learn a little bit about process improvement, how to do the post-it notes and process mapping, and then really tackle a problem that was important. And of course, without a doubt, it saved us money in any one of those. Starting the ORs on time, getting turnaround time shorter, reducing paperwork bureaucracy, getting our clinics to run more efficiently. All of those improved the bottom line for us. And I think that was really, for us, it turned out to be a very good way to do it.
Great. One question that came up that I think relates directly to what you said is kind of this focus on how you're defining your metrics, both for quality as well as is not thinking just about cost. And what the question that came out is, how do you really define quality? You talked a little bit about patient surveys, but is it broader than that? And what was your approach to think about that?
Sure. So our quality metrics are like any other healthcare system's quality metrics. We have all the CMS core measures. We have all the subspecialty measures for surgery. We have those hundreds and hundreds of quality measures. What we did for our orthopedic surgery initiative, which I showed you very briefly, when I showed you the quality index going up, that quality index, which they called the perfect care index, is actually a blended index of various quality measures. Some are the ones that we are responsible for that determine whether we're reimbursed. And then some of them are actually physician-defined metrics. So, for example, the orthopedic surgeons feel that one of the most important predictors of good outcomes is that the patients need to get up and out of bed the day of surgery. If they get up and out of bed the day of surgery, they will have a shorter length of stay. They'll have fewer readmissions, fewer complications. And so they added that to that perfect care index. So they're the standard quality measures plus some things that we've added. And of course, we would like to add more patient-reported outcomes measures as well. And the reason why I think this, or an example of how this is so helpful, I think, is what happened in that orthopedic case. So one subset of patients they discovered were not meeting the 100% perfect care index that they were aiming for. And that was because they were not getting up and out of bed the day of surgery. And when the orthopedic surgeons, because they had access to this data in real time, when they looked at it more carefully, they discovered that those patients had one thing in common, which is that they were coming out of the operating rooms late in the afternoon after the physical therapist had gone home by early evening. And so they weren't getting that up and out of bed experience. And so we just simply made 2 shifts of physical therapy, an earlier and a later shift. And now those patients all get up and out of bed the day of surgery, shorter length of stay, fewer complications, lower costs.
Great. You know, I think we're near the half-hour mark, but I did want to ask one final question to you, which is, you know, talking to folks across the country that are, like I said, starting in some of this work, what are 2 pieces of advice that you would share with them, and including potentially things you wish you would have known before you and your team had embarked on this?
Oh, that's a great question. I'd say one piece of advice that is, I think, very important is to be optimistic. So one of the things I feel is there's so much doom and gloom about healthcare and healthcare reform and all the change that's facing all of us, that sometimes that can be oppressive, and you can think, how am I going to get out of this? You know, whether it's at the individual level with the new EMR and all the bureaucratic things that I'm have to work with, all the way up to system leadership levels where you feel like payment reform, so many things that are unknown and challenging. But I actually feel like we are at one of the most opportune moments in history in healthcare. We have the chance, we know, most of us who are in healthcare know that there is a lot of waste in the system. There's a lot of inefficiency in the system. There are ways that we can definitely deliver better quality care, really engage patients much better than we've ever had before, and clearly we can tackle costs. I mean, our experience in the total hip replacements and the 30% reduction without even trying very hard, I think really illustrates that. And so there's just enormous opportunities to transform our healthcare system to be something that will be the best in the world, that would be something that would be a point of pride for all of us. And I think we have all the tools, and we certainly have the brain power and the capacity among our physicians and our care providers and our leaders to do that. So I think that would probably be, maybe I could just limit it to one point of advice, I think that would be my point of advice.
That's great. I mean, I think one of the things I've heard you speak a number of times, and I'm always inspired hearing about the story and kind of the process that's gone through it, is that talking to folks around the country, there's a lot of that doom and gloom that you mentioned, where I don't know if we're going to be able to do that. The providers may not be interested. We're getting a lot of pushback, but it's the vision that your team had to kind of cut to the chase of what can be done, and that even in that orthopedic example, that big change can happen even with moderate interventions. That there's a lot that can come from it, and I think your story is wonderful to display that in this setting of the webinar. So I want to thank you so much for joining us today, and for all of the listeners for such a great discussion. I think there'll be a lot of views of this over the next few weeks as well, in addition to our live viewers. And to let the viewers know that to remember to check out the tools for educators and system leaders, we'd love to be able to post the link that connects to your Value Fellowship and some of the other work that you're doing, and definitely refer people to contact your team in regards to thinking about expanding some of these efforts, as you mentioned today. So we'll point you towards next month's webinar that we will have and be posting about on our live discussion on our discussion board. And so thank you, Dr. Lee.
Thank you. Thank you very much, Reshma.